to give his talk about radiotherapy for localized prostate cancer, normofractionation, hypofractionation, or stereotactic irradiation. Is shorter better? I hope I will understand a difficult thing. Thank you very much.
Thanks a lot, dear Chairman, ladies and gentlemen. The topic of my overview, what is the best, normofractionation, hypofractionation, or stereotactic irradiation, is a little bit confusing, even partly for radiation oncologists, because these points, I have to work on it. The standard is normofractionated percutaneous radiotherapy, but why? And do we really need IMRT plus minus IGRT? And hypofractionation needs a look into the alpha-beta value. That's a radiobiologic topic, a little bit difficult. And then, quite interesting, the combination with high-dose rate brachytherapy, which is also in hypofractionation. And last but not least, stereotactic body irradiation, and the same one, the cyberknife. And is shorter better? That means is shorter at least equal in the tumor outcome, or has it less side effects? All these things we have to discuss. The first point, what is the best dose we have to use? This is a meta-analysis of 7 randomized clinical trials, and you can see the dose volume curves for low, intermediate, and high-risk prostate cancer. And it's clear that you can see that the higher dose, for example, 78 gray, is clearly better when you look on the fitted curves. And you have to take in mind that 78 gray with 2-grade single fraction is the same, for example, when you look for radiobiological terms with 1.8 gray up to 84. So these are data from the Memorial Sloan Kettering Cancer Group with 2,500 patients treated with IMRT up to 86.4 gray, with 1.8 gray as a single fraction, so this is the same as 78 to 80 gray. And when you look into the results, then this is retrospective. The higher doses, clearly significant, highly significant, better the higher dose, and in combination then for high-risk patients with androgen deprivation therapy, and also another benefit. So dose does matter, but this is retrospective. And now we have newer data from randomized trials. This is an RTOG trial, a phase 1/2 trial published in the Red Journal 2012 with 1,000 patients, and they started with dose levels of 68 gray and went up to 79 gray. And it's interesting when you are looking for the dose of 74 compared with 78 gray for high-risk tumor, then you see that the estimated 10-year rate of biochemical progression decreased clearly. So in the guidelines, this is the updated version from 2014, published in European Urology. We said that you have to use a dose of at least 74 gray for low-risk tumors, and for intermediate and high-risk tumors, you have to give from 76 to 81 gray, and this is so-called standard. The techniques we are using today, this is fast intensity modulated radiation therapy, for example, rapid arc. This is one example, and you can see that when you use these techniques, you can spare a lot of normal tissue of the bladder from the high dose, and the same one, this is the irradiation for the pelvic lymphatics, the same is with the rectum. The point is, have we data that IMRT is better than 3D treatment planning? This is from the SEER database, highly ranked, published in 2012, a propensity matched weighted matched pair analysis, 6,000 patients with IMRT compared with 6,000 with 3D treatment planning. And you can see the clear decrease from gastrointestinal events and also from hip fractures. And when you look for the results of additional new tumor treatment, a clearly decrease in case of the patients treated with IMRT. This is retrospective only, but it's a huge series. The problem with IMRT is not with rectal side effects. I think the real problem is the risk of genitourinary side effects, and these are also data from Memorial Sloan Kettering Cancer Center, and you can see that the grade 2+ late side effects increase over time, even after 10 to 15 years, very, very late coming. So this is a real problem we have to look for IMRT. These are data also from the radiation therapy oncology group 01 to 6 prostate cancer trial, and is low dose 70 gray compared with 79 gray prospective, a phase 3 trial, and they stratified from the middle of the time on between 3D and IMRT, and these are the first data published about within a randomized trial of the use of IMRT. And what you can see clearly for late GI tox, you have a clear, significant lower cumulative incidence of grade 2 plus, also of acute. But the late GU tox, there is no difference, as I told before, and as expected, only of acute toxicity. Do we have to use it with IGRT, with image-guided radiotherapy? These all different in-room 4D tools. Normal-wise, we use cone beam CTs or gold markers or other fiducial markers. And we have, up to now, some incidents that it helps. These are also coming from the Memorial Sloan Kettering Cancer Center, 376 patients. They looked retrospectively, dose 86 for gray, and the half had daily IGRT, and the other without daily IGRT. And you see that the late toxicity grade 2 plus decreases for 50%, but it came from 20%, and that's for 2 and plus, that's a lot, even with 10%. And there is some sites that for high-risk cancer, it's better with an increase of the biochemical free recurrence rate. This is another interesting retrospective series from the University of Melbourne, from the Green Journal. And you have here a series of 300 patients with non-fiducial marker IGRT and 274 patients with 78 gray higher dose and with fiducial marker IGRT with daily imaging. And it's quite interesting when you look for the incidence of moderate and severe GI late effects, a clear advantage with a high hazard ratio in favor of the daily imaging. Also, when you look for prevalence of moderate and severe GI toxicity and of GU toxicity, there is a significant decrease of side effect using daily imaging. And this is despite the dose escalation. Next point is hypofractionation. Hypofractionation means daily dose is more than 2 gray, up to 3.5, 3.6 gray. And the problem is we have to look for radiobiological items, the alpha-beta ratio. It's a radiobiological description for radiation sensitivity, and it's clearly estimated on the basis of experimental and clinical data. And normal-wise, it's high, between 8 to 10 for tumors. And there are a lot of signs that for PCA, it should not be so, probably below 2. And when it is so, then then it's also lower than for rectum and bladder, and then it suggests a highly significant fractionation sensitivity, and then, that's the third sign, higher single doses would be better in the treatment of prostate cancer. The problem is, what is when it is not? These are the most important running phase 3 trials. The first one from the Fox Chase Center has been published recently. The other ones are running with altogether 5,000 patients. And what you can see here that's very important, the standard, for example, for the Fox Chase Center is 76 gray, compared with 70.2 gray with a single fraction of 2.7 gray. When the alpha beta is 1.5, then this fractionation gives a total dose of 84.3 gray. Is it 10, you have a lower dose than given in the primary arm. And so we have five major trials, and this is the first one published in the JCO recently before, 300 patients accessible, 5 years median follow-up, and very important, all of these had daily IGRT using ultrasound image guidance. And the primary endpoint, please look at here, when the alpha beta is 1.5, they said we have 84 gray, and then we think we have an improvement of biochemical disease-free survival in favor of hypofractionation up to 30% from 15% at 5 years. And the point in the results, the trial was negative. The endpoint failed. There was no significant difference. using the ASTRO, the Phoenix definition for biochemical progression-free survival, no difference, and also not for overall survival. And the problem now is that radiation oncologists have a problem because perhaps the alpha-beta estimation was not correct, and we have a second trial coming from Italy saying the same. The side effects for hypofractionation from the Fox-Chase trial, you can see no significant differences. That is also important for the daily treatment with higher fractions. Except one case, these are patients with an IPSS of more than 12, and it's clear we have to aware treatment with hypofractionations because you see that there is a clear, highly significant increase in late side effect for these patients. When you use this in combination with high-dose rate brachytherapy, this is also Memorial Sloan Cancer Center data, retrospective, 230 patients, median follow-up 5 years, and they give as a hypofractionation 3 times high-dose rate brachytherapy within 24 hours. That's a very high dose. And they gave additionally 50 gray of percutaneous irradiation. This is retrospective, but for the high-risk tumors, you can clearly see that after 4 years, only 19% of recurrences, which is very low for this group of patients, and an acceptable rate of late side effects. So that's very promising, but it's retrospective. Coming to the last topic, stereotactic body irradiation, where patients are immobilized, very rigid. You can see here one of the major series published in the JCO 2012, and you see that they gave in 5 fractions 45 to 50 gray. That means 9 to 10 gray per fraction and per day. And the toxicity of these arms from 45 to 47 to 50 gray show that there are about 7% of the patients with grade 3 side effects and about 30% of these patients with grade 2 side effects. But the follow-up is too short, so Anthony D'Amico said no treatment outside well-defined clinical studies for the moment. And this is also 2 years later the point. And this is the major series recently published in the Green Journal of the CyberKnife treatment, 8 institutions, 1,100 patients with localized PCA, and they used the CyberKnife system all with a median dose of 36 gray and 4 to 5 fractions, only 3 years of median follow-up. And what you can see here is that, as expected, there is a relatively high rate of recurrences within the high risk treatment, but these are very early results, and when it's very questionable to give 5-year data when you have a median follow-up of only 3 years. So for the moment, it's clear the side effects are coming in the second paper and have not been published until yet. So it's clear for the moment this is no standard treatment. Another point, it's the last point, very interesting. The FLAME trial, coming from Marco van Bulpen from the Netherlands with 600 patients. And these are patients with intermediate and high-risk PCA. The standard is high, 77 gray. And then the experimental arm, they gave an integrated microboost up to 95 gray within a randomized trials. All have fiducial markers, all have for treatment planning multi-parameter MRI. And they estimated after 5 years, an increase of 10%, and the trial has recently been completed with more than 500 patients. And I think this is one of the most important trials for the moment we are waiting for. Is shorter better? I think radiation oncologists have to be a little bit careful what they are doing. And I think for the moment, it's better to wait and not to use these high single fractions than other of our colleagues will show if the late side effects will increase or not. I personally would not be the first to show that there are an excess of late GU toxicity or so. So I think this picture describes the problem relatively fair. Thanks a lot.
Thank you very much for this excellent overview. Is there any question? Yes?
I have a question. Those data you showed from the high-dose rate brachytherapy from the Memorial, did they combine it with hormonal therapy?
Yes, in part because it's a standard, but they compared it then with the standard treatment of 81 to 86 gray, also with 6 months in the high-risk group of androgen deprivation therapy. And there is a clear difference in favor of the additional use of high dose rate brachytherapy, but all of these had androgen deprivation therapy.
So therefore, what is the standard of care for high-grade prostate cancer? Is it brachytherapy plus additional radiation therapy, or is it solely IMRT?
For the moment, I think it's solely IMRT because these other data are only retrospective. There is no phase 3 study, and we have a lot of phase 3 studies. And I think based on these data, the Memorial colleagues have to do a phase 3 trial.
So the follow-up question then, why is anyone doing brachytherapy any longer?
No. There are a lot of colleagues who are doing that.
My question was, if the standard of care is IMRT,
Why are doing it so?
Why are they continuing to do it? Why do we not switch everything to IMRT?
The point is, it's like for these colleagues who have the robotic surgery and these who do open surgery. These ones who are very experienced in one part, and we have colleagues who are very experienced in the high dose rate brachytherapy. They do this as a boost, and it's also comparable from the results. It's also allowed to do so. So I think for these experienced colleagues, it's clear they can do so. But without any experience in this, I would not recommend to do it. We stopped it 10 years ago, and we do only IMRT.
Thanks for a wonderful presentation. In a meeting like this, you will probably often be asked for secondary cancer, and I hate to ask you again, but I want to know about the time frame. Is it? Do we have numbers now that we can say in the first 10 years no risk, is such and such after 20, 25 years? I ask this in relation to the age of my patients. You know, if you knew the time frame, then a 75-year-old man wouldn't care about it, but the 50-year-old certainly will. So I will ask this.
I think the risk of secondary radiation-induced tumors is clearly there. There are valid estimations that for example, for treated prostate cancer patients after 10 years, it's 1 out of 70 irradiated patients who will have a secondary induced tumor. I think that's serious, and the excess of these problems perhaps will come after 20 to 30 years. I would think so. But we have no data of such a long follow-up in patients treated for prostate cancer. But it is a problem. And for myself, I do not intend to treat patients with 50 to 55 or 60 years as a primary treatment. I think radical prostatectomy in these patients is the better variant because we can help our colleagues when the PSA increases later on, like Marcus will show in the next presentation.
So, Thomas, I thought that was a fantastically considered presentation. So I have two questions. I think your last slide said it all. Is the nature of radiotherapy that we're giving patients is about to change. So, in other words, from a lesion that works over months to an ablative lesion that works over seconds or minutes. And I think we're on the cusp of a revolution. So I'd just like to comment on that. The other one relates to the last question, is your thoughts on the very slight excess all-cause mortality associated with radiation therapy that we're starting to see in numerous studies. The breast cancer studies recently published in the Lancet of intraoperative radiotherapy versus whole breast radiotherapy, slight excess of all-cause mortality. The Hamburg series yesterday in patients receiving radiotherapy, also a slight increase in all-cause mortality. I think there are 2 or 3 other series about whether radiotherapy and a big dose of radiotherapy incites some systemic inflammatory response. You can do the last question first. First of all, do you accept that there's a signal?
Please precise the question a little bit because it's not so easy to answer.
So do you accept that there is the beginning of a signal suggesting that radiotherapy to any part of the body results in a slight excess in all-cause mortality compared to a control? No.
No.
then we can't
No,
proceed.
no.
Okay. Yeah.
Yeah,
So,
I have to think a little bit about it because you look for breast cancer.
Yeah.
Yes, it's not so easy to say it for all. So I need 20 seconds for it. But for the moment, I would say no because such clear data we don't have.
Okay, fine. So what about the radiotherapy is changing dramatically? So the lesion that we created that worked over months, which was a vascular injury probably, is now become an ablative injury with the new technologies.
Yeah, but the problem is really even with multiparametric MRI to detect the dominant lesion and the precise volume of it. I think it's pretty good to detect it, but I think the problem is the precise volume. When you have to irradiate with these high doses, you have to use a very, very precise dose-volume definition. And Marco van Wulpen did this with all what they had. It's a wonderful study. I was very impressed when I saw the technique he used. And, but the problem is, for my personal feeling, when you give microboosts or these things, and you will fail about to 10% of the tumor because you can't see him even in multiparametric MRI, then you have a real problem.
Okay, thank you.
Thank you. I think we should move.
Okay.
Yeah.